Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
You may want to start with the last one you
Yeah,
said.
I am. Let me clear the screen. Hold on.
Well, this new administration has started off with a bang. Now, can't say that we're surprised, but starting off exactly as we expected he would start off. And the best, of course, is yet to come.
Yeah, he's stopping Medicare from negotiating prescription drug prices.
Right.
He stopped the research into finding ways to lower drug prices.
Yeah, right. Well,
Okay, here we come, and here we are. There you go.
yeah. So we can't say that this is surprising, but this is what is expected, that Trump would reverse things. It's just that he didn't waste any time the first day in office. He's always hated Obamacare and drug pricing, of course, impacts people at the top level of the money making uh, folks. So anyway, he's reversing as much as he can, and of course, lowering prescription drugs is an interesting way of doing it, because of course the big pharma will be delighted, I'm sure. Of course, the average person in the street will be affected by this. And as we were talking about the Medicare prescription prices and all of that, with Part A, B, C, and D of Medicare, it's going to be interesting to see how these things work out. It's going to be interesting to see how he moves in all the other arenas that he has promised to move in.
You know, it's only because it had Obama's name on it. He hates Obama.
Right. Yeah. Right. Yeah. Anything he's done. Yeah. Mm-hmm. So it's going to be interesting to see what happens to DEI and all those other things that.
I'm really surprised because I mean this affects so many people, uh, white and black, and it seems like there would be a backlash.
Well, if there is one, which I doubt, it'll become when people recognize the impact of it. They may not realize what this means yet, but they will in February. I think Big Pharma's happy though. Any other comments? None of this is unexpected. So,
Okay, moving on.
this is an interesting idea that we get a that our flu shot protects us against the potential avian influenza pandemic, although pandemics usually are about 100 years apart. But because of the bird flu and other things, avian flu pandemic is something that we fear. And it's one of the thoughts is that the flu shot protects us to some extent for some of these xenoantibodies that xenoantibodies mean antibodies that are specific against other species like the birds and other things. So one of the hopes, and this is more of a hope than anything else, is that our flu shots will help us prevent a avian pandemic. So the long and short of it is that get your vaccinations and we'll hope for the best. Yes, Dr. Perez.
And I guess the removal of the United States from the World Health Organization doesn't help us with epidemiology from a global standpoint.
Yeah, that's the other thing that he's already done. Yeah, so he's moving his dictatorship onward. Yeah. This is the CDC recommends faster testing for bird flu. And they say if you hospitalized with the flu, that within 24 hours, you should have bird flu testing. So they have the wherewithal to do it. So those people who are hospitalized for the flu, this is one of the things that they're recommending because they're fearful of a bird flu pandemic. Yeah. Nearly 70 people so far have contracted bird flu since April. So it's and with one fatality already. It's a fear that seems very legitimate. Next article, please. We talked about this last week, but I included this because they're still talking about why we're having this spike this season rather than any other season. And I think one of the things that they talk about is they talk about the different kind of strains of norovirus which change. But one thing that they don't talk about is something we mentioned last week, but I'll mention for emphasis again. And that is we have a tendency to use the alcohol sterilizers for our hands and not soap and water. And the norovirus is resistant to alcohol. And so if you don't wash your hands with soap and water and you use a sterilizer, it will not kill the virus. And so you can continue contamination of this a virus that comes from hand to butt kind of way. And the soap and water, some of us have gotten away from soap and water, and for those, it's a reminder that soap and water is still the best. There are many bacteria and viruses that are susceptible to the alcohol, but norovirus is not one of them. And it is far more common this year than ever before. And you have the double whammy of vomiting and diarrhea at the same time, and fever and chills. And so it's usually short-lasting, but in the elderly, it can be a cause of serious illness and even death. So the moral of the story is don't do away with soap and water and washing your hands, and try to remember to wash hands as frequently as possible, particularly if you're shaking hands or touching other people.
Good morning, everyone.
Okay.
I love this article because even during the pandemic, when everybody was using the hand sanitizers, I never got away from my soap. I I just felt like soap was I've been cleansing myself with all these years. So why stop now? And
Well, this vindicates you.
so
Yeah.
I had my soap.
Soap and water. Back to the elements. Okay. Any other comments? If not, we'll move on to the next article. And this is that aerobic exercise that we've been talking about that you need to do 150 minutes a week. Reduces belly fat and is something that we need to continue to do. It's helpful in so many ways. It's just another way in which aerobic exercises. And we'll see articles that talk about improvement in depression and sleep. There's so many ways in which aerobic exercise 150 minutes a week helps you be better. So something that we should do. And of course, you want to address body weight, waist circumference, and body fat. All of that is addressed by aerobic exercises. Nothing new, but just a reminder that the minimum of 30 minutes a day, 5 days a week is still something that is very desirable, and especially after you reach the age of 40. The only place that fat is good is perhaps in the butt, because there's evidence that people with big butts can be healthy, but people with big bellies aren't. Okay, so let's go to the next article, since this is something we talk about every meeting. This is just an article that points out that 7,000 or more steps a day lowers the likelihood of depression. So we know about many things that exercise does. We sometimes don't recognize that it's extremely good for your mental health as well. And so this is an article that emphasizes that, based upon studies, that a significant number of people, 96,000 adults, has demonstrated that it works, and especially for mental health, along with the other things we've already talked about. Let's go to the next one, article. Plant-based diets, is we talked about that for dementia. We also decreasing the risk of dementia, also reduces cancer risk. This is, again, nothing new, not something that, but when they compared vegans and vegetarians and meat eaters, it was clear that the meat eaters had the higher risk for colon cancer. And as they looked at what were the common issues, it was that the plant-based diets were the best diets to decrease the cancer risk. And so this is a reminder to us that fruits and vegetables is the way to go. And the more vegetables and fruits you eat, the better off you are. The more meat you eat, the worse off you are. Any comments or?
Where does junk food fall in that category?
Well, we know that junk food fits into the same category as meat. So
Oh,
I think we know that the French fries and all those things we love so well are killing us, even though we still eat it. So, but junk foods and meat are in the same category. And the reduction of breast, pancreatic, and prostate cancer, all associated with plant-based diets. And there's so much data now that is almost indisputable. Any comments or questions as we once again get more and more data that the more vegetables and fruits we eat, the more exercise we do, the better off we are. 3 million participants. The data is so overwhelming that it's hard to say anything. So much data on this subject. Any comments or Darryl?
Yeah, we've been well, for years we've been talking about the benefits of plant-based diets, and I don't recall any increase in the number of vegans in this group session. It seems to be pretty steady at one. Um, so, so I'm just wondering if we could get some comments for why people just totally dismiss. We hear that plant-based diets are the way to go, but nobody's going.
Well,
Um,
that's not true. Now you said vegans or vegetarians, but the article doesn't say that you cannot eat meat. It said that you should have a plant-based diet, uh, and the more fruits and vegetables you eat, it doesn't say you can't eat meat at all. It says that the more vegetables and fruits you eat, the better off you are, and the more meat you eat, the more likely you are to get cancer. It doesn't say you have to eliminate meat.
right. Um, but I'm just wondering why, um, getting some comments from the group.
Yeah,
Why,
let's hear some. Let's hear
why
some.
y'all dismiss the prospect of being vegan?
number one, because we like the food we've been eating all our lives. But I I have though, seriously, I have cut back on eating meat. I don't eat as much meat, and I do eat more salads and things like that. But as you get older, I guess it's just hard. It's harder probably than trying to convince a younger person to start eating vegan if you've been eating it and enjoying it all your life. But I have cut back on eating a lot of meat, and I'm trying to diet anyway, so I've cut back on food, period. But I still every now and then enjoy junk food. And so my husband always says, he isn't in here right now, but he says his doctor always tells him anything in moderation. So that's kind of what I base it on. But I do realize that meat, and particularly red meat, I eat more fish and chicken than I do red meat. But, you know, I guess, baby steps, but it's hard to just cut back totally.
John is next. John Buchanan.
Yeah,
You're mute.
I agree with Betty in that those habits that we grew up with are really hard to break. Um, but I think I told a group. I think I was about 26 years old. I took a colorectal cancer test, and it came back positive. They found blood in my stool, and from that point on, I stopped eating red meat. No hamburgers, steaks, things like that. Uh, about 10 years later, after numerous negative colorectal cancer tests, I went back to eating my bacon and sausage, but still, because I love bacon, love it. It tastes great, to me. Um, but I still stay off of the steaks and the hamburgers. Um, and we go out like a couple times a month with fellas to have lunch or brunch or whatever. And uh, in both of those groups that I go with, one is teachers and one is other friends. There's at least one guy in the group. I think the last group there are two guys that are vegetarians. So we get a chance to taste vegetarian meals, and some of them taste pretty good, pretty good. So I think just the idea of less meat and more veggies is part of the change. You know, expecting somebody to stop cold turkey, no pun intended, uh, would be kind of hard, I think.
Earl Lipscomb.
Well, I just wanted to say that I guess I guess I'm living proof that the vegetarian and vegan diets do work because I was diagnosed with uh, kidney disease, and my doctor told me that if I did not stop doing what I was doing and switch to a plant-based diet, that I probably wouldn't be here now. So this was about 5 years ago, and I have been told that my kidney disease my kidneys have improved by over 40% since I started on the vegan vegetarian diet. So, and I do eat very little red meat. I do eat chicken, and grilled bacon also, which I do eat sometimes, but mostly it is fruits and vegetables. And I just found out there are a lot of ways you can cook vegetables, and they're pretty tasty.
Dr. Perez.
I think most of my comments have been shared, but a tenet of what everybody is saying is the relationship or the celebration around certain foods. And it's more the relationship than the actual foods, as our dear sister Pearl Lipscomb was saying. When we can transplant or we can take the emotions that we had around collard greens and hog maws and dripping macaroni and cheese and ham and all of that, and replace that with a nice stir fry, a crisp salad, legumes. We can change that emotion and move and celebrate, because it's usually the celebration and the camaraderie around food and not the essence of what we eat.
Jacobin?
Yes, thank you, sir. Good morning, everybody. Um, I've grown to not like to cook. I live alone, and what I have to buy the food, bring it home, unpack it, put it away, then cook it. And when meat, I just I don't have I just don't feel like doing all of that cooking. Of course, when I'm out, to friends or out to a restaurant, I might have a piece of red meat, but I mostly eat salads and like somebody else said, fish and chicken, because it's so much easier to cook. And and I found out that those what do you call them? Snap peas or sugar peas or something. Really enjoy those things. I've never eaten them before. I've seen them and all that kind of stuff. And I got some the other day, and I tell you the truth, I have really enjoyed those snap peas. And with the greens, of course, I grew up on collard greens and cabbage with all of the fat back and all that stuff in it. I've never cooked them that way because I didn't understand the fat back. I didn't like that. But it's amazing at what you can do with plant-based diets. I'm not saying that I'm fully a plant-based dieter, but um, I just don't like to cook.
Any other comments? Okay, well, I think we've heard from your folks. So,
Thank you, Darryl, for sparring our conversation.
okay. The next article is, Darryl, you had something else to say? No. Next article is keeping blood pressure under control, and it's interesting because we discussed this last week, and here we have an article that talks about the new a new option, which kidney denervation, and this article goes into actually how they carry out the denervation for those patients who are not responsive to the medications, the many medications that are effective for lowering the blood pressure. And this article talks about the denervation option, which is something for those people for whom medication does not work. And they, as you move down the article, they talk about the fact that if you're unable with medication to get down to 120/80, that you can have this surgical procedure in which they actually uh, deaden the nerves that go to the kidneys. Now they talk about more other things that are easier to do, but they also talk about the fact that there are some people who, in spite of the usual medications, don't respond. And if they continue to have blood pressure over 150, over 100, then this is the process that they do to do it. This is not something that is often done, but it's something that they do. They describe the renal denervation process right here, how they put you to sleep and they thread a catheter to reach the kidneys, and then they use ultrasound or radio frequency to selectively target the nerves. And this nerves, they had a trial about a decade ago, and the problem with that is that it didn't last forever. it worked, but it wasn't a permanent fix. But it is something that's denervation is that's available if the all the medications don't work. I'd say 90% of the patients who take the medication as they're requested have a result, a positive result in getting normal blood pressures. But what is disturbing is that the death rate from cardiovascular disease hasn't changed in the last 10 years, suggesting that what we're doing now is not good enough. And one of the things we're finding as we screen patients is that they aren't taking the medications, and uh, this is probably the biggest problem. Mr. Buchanan.
Yes, so why does the kidney, is it the kidney or the liver? Why do the kidneys have nerves anyway? What are they
Well,
used?
every organ has nerves. Because it affects all of the blood vessels. They narrow or dilate based upon innervation, so that every organ that you have has nerves. So the kidney is no different, and it is thought that if the uh, blood vessels constrict to the kidney, then this would cause the blood pressure to go up. If they dilate, this would cause the blood pressure to go down. So that the kidney denervation is thought to therefore work in that fashion to decrease the vasoconstriction, which is associated with increasing blood pressures. Any other comments or questions about this interesting article? But I think the real bottom line is that we need to take the medications that are prescribed the way they're prescribed. And probably if we do that, that would decrease the death rate from cardiovascular disease and normalize the blood pressures for 90% of patients. There's a comment?
Callender. It sounds like this procedure would also help stabilize the function of the kidney.
Well, we don't have any data to say it will stabilize it, but because that study hasn't been done. So,
Dr. Callender, why did they choose the kidney, the organ of kidney rather than some other organ? Is there
because the kidney is the place that angiotensin hormones and other hormones that are produced that cause hypertension, and so that's why they chose the kidney. Many of the hormones that are associated with uh, lowering and raising the blood pressure come out from the kidney. Angiotensin, and many of the blood pressure medications are act on the kidney. So that's why they chose denervation of the kidney.
okay?
Doctor, is that a surgical? It's a surgical procedure.
Yeah, in the sense that they put a catheter into the renal artery, and but it's in a way you can do it without surgery, uh, but they may put you to sleep to put the catheter in, or they may not. It all depends on your mental state. But after they put the catheter in and they get to the arteries, then they use radio frequency and ultrasound to freeze or deaden the nerves.
Very interesting.
Yeah, interesting. Something else that can be done with, but when the real issue is taking the medication as prescribed, it's the best thing to do first. Okay, let's go to the next article.
I hope they do something on that study that you said that they haven't done, because they might find a value in doing procedures like that to improve kidney function?
Well, I think the most important thing is take the medications, and there's there are a number of people who have modified their kidney function just by changing their diet. You've heard testimony of the vegan and vegetarian diets, and also just the elimination of meat from the diet, how that has impacted uh, and improved kidney function. So, but anyway, there's not enough much data on this, so we'll have to wait and see what happens. Any other comment on that article? Healthcare artificial intelligence is something that is going to be a critical part of the practice of medicine in the future. And this article is saying, yes, that's true, but it's going to require uh, scientists and doctors to work along with the healthcare system in order to make it work. And so, of course, it also is going to require us to do things to take out the biases that are already in the artificial intelligence system. And so all of this requires man-made influences. And so that AI alone can't be the answer, but the combination of AI and the scientists and the doctors will go a long way to improving healthcare of human beings. And so this article is just pointing out that can't do one without the other. And the working together is the issue that will bring many benefits to science as a consequence of the artificial intelligence. That's the long and short of the article. Any comments on, we've talked about AI for quite a while now, and it's clear that it is going to make a big difference in the practice of medicine. But we can't leave out the human element and the importance of taking out the biases that we have already introduced into the medicine. Dr. Perez.
And the economic component, because we have seen over and over that greed has so often overrun good.
The love of money is the root of all evil, the good book says, which goes along with your point.
So the mention of expensive humans in the topic, in this article's topic, they're talking about the expense that it's going to take to make enough doctors to do this, or the expense that it's going to take on the patients who have to pay for it. Which one?
We're talking about the need for scientists to work along with the AI. That's what they're talking about.
Yeah. Okay.
That's going to take a working together of the humans as well as the AI, the scientists and the physicians and healthcare providers. So that's what they're talking about. Any other comments or questions about this interesting article?
Because I think the essence of what you said, Dr. Callender, about a lot of trash that is in AI, in terms of biases, racial bias, that hasn't been removed from it. And our absence, just what your first article about some of the executive orders. Everybody in the federal government that was in a DEI position was put on administrative leave if that was in their in their title, and then watchdogs placed. So I'm saying now information and the release or the inclusion of that information is now held in a biased status, which could be critical. We know that social media platforms have removed the necessity of fact checking.
Any comments? Yeah, that's very true. All that's very true. So it's and all of this then means that the likelihood of some of these biases being addressed is going to decrease with this administration. But in order for AI to be at its maximum, it needs to be purified, and that requires human intervention, and that's the additional cost of making AI work for everyone. Next article. This is another contribution that AI has identified, looking at retinal blood vessels, that they're able to make an earlier diagnosis of stroke or predict when you're going to have a stroke. And this then is another way in which AI will work together with healthcare providers can improve our health, make earlier diagnosis. We've also seen that working with pathologists, radiologists, and other healthcare providers that can make a huge difference. So it's an important difference that needs to be made, and the working together of the scientists and healthcare providers and the AI is something that is invaluable. What will be interesting is to see how this administration addresses it. But although this is happening all over the world, so it's not only the United States, it's everywhere else in the world is doing it. So hope that we keep up and don't let our biases keep us from doing the right thing. Darryl?
Yeah, I see this. The data came from a UK study, and they're looking at it in Australia. Is this test available in the United States?
Not yet. And it's going to be interesting to see how these findings that AI occurs across the globe are done in the United States. And that's one of the concerns that one ought to have with the biases that our new administration is going to bring to the table.
Yeah, this would be really valuable for anybody with a family history of strokes.
Absolutely. Absolutely. And this is the kind of thing that will happen in just about every aspect of healthcare system, ways in which the AI can make things better, and the working together of the AI specialists and the healthcare providers becomes awesome. On the other hand, if we don't have that working together, then the United States will fall far behind, because other countries are taking advantage of it. Okay, next article. We talked about the what's the best approach for sustained weight loss? And we talk about nutrition, drugs, or bariatric surgery. And as Darryl and others have mentioned many times, the United States, 50% of the people are overweight or obese. And so more than 100 million with 22 with severe obesity require interventions. And so what's the best approach? And it's hard to say because you have the glucagon derivatives, the new drugs, you got the diets, and you've got the bariatric surgery. And what's the best approach? And you can see that there are all kinds of approaches. All of them work to a certain extent. Some people able to do it by diet alone. Some people will do it by use of the glucagon medications, and some are able to do it by bariatric surgery. So, which is best? I guess to me, if you have severe obesity, bariatric surgery and actually the medications, along with the lifestyle changes, seem to be the best treatment. Although it's kind of hard to eliminate bariatric surgery for those who are severely obese. Talking about BMIs greater than 40. And so as it goes down, it talks about the fact that what is overweight, what is obesity, and what is severe obesity. And I think that the treatment is different for whether you're just overweight, whether you're because if you're just overweight, lifestyle changes might be all you need, and nutrition. But if you're morbidly obese, meaning more than 40, BMI more than 40, then the different kinds of bariatric surgeries are important, and also the glucagon derivatives become important. But all of them seem to be essential to them is lifestyle changes, along with all of the other treatments. John Buchanan.
What is the AOM? I missed that.
That's the you want to go back up to the top to see?
Okay.
Anti-obesity medications.
Okay.
That's the glucagons.
Right. Okay.
Glucagons. Yeah. And in this day and age, there's so many people who are trying the glucagon derivatives and injecting themselves with glucagon derivatives. Prior to 5 years ago, it was the bariatric surgery was probably more common. Now, GLPs, the glucagon derivatives are. And of course, the glucagon derivatives have their own issues. John, you had another comment, or you saying that?
Yes. What is the definition of bariatric surgery? I've heard a lot of different.
Bariatric surgery is surgery to reduce the stomach. There are ways of diverting the stomach, either taking out half the stomach or diverting the stomach to the intestine, or just doing an intestinal bypass. There are 3 surgeries that they have there that they use to get people to lose weight. And most of them involve just really cutting this. What they do is taking the food that goes in the stomach and reducing the size of the stomach to about 10 to 20% of what it was before. Either that by procedure or by bypassing, going from the stomach to the intestine quickly and bypassing the duodenum, the small intestine, part of the small intestine. And this, and then there's also another mechanism they have, which all you do is you put a tube that goes directly into the intestine, and this causes a hormone to be produced that uh, stops the brain from wanting you to eat. So you've got all these kinds of ways of getting you to stop eating so much. The bariatric surgical procedures really reduce the time that your food is actually in the stomach. So, and some of the stomach procedures, they block off 2/3 of the stomach, and so you only have a third of the stomach that actually has food in it.
I'm glad you explained that because I was thinking that they just go in and cut out all the fat.
No, 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 no. That's a different. That is not even included in this because that's just a process of taking out the fat when they don't consider that bariatric surgery. That's you see these commercials where you have these. It's interesting that they only have women in these commercials. They don't have men, but they have women who have the fat removed, and of course we know that there are complications from those fat removing procedures that have cost women their lives. But they have not included those in this because that isn't so much about weight gain as it is for tailoring the body and making the body more beautiful or making it slimmer because whether it's more beautiful or not is beauty's in the eye of the beholder. Uh, any other comments or questions? Because this is a very uh, interesting subject. And since most of Americans are overweight or obese, this is something that we need to be aware of.
My question, Dr. Callender, would be of these different types of surgery, um, some are pointless to attempt to reverse them, and some of them you can't reverse them.
So what is your question?
Um, which ones can you undo, and which ones are permanent?
Well, I think all of them can be undone. Uh, but when you uh, clip off 2/3 of the stomach, uh, I think that's one of the hardest things to redo. If you just do a bypass, you can convert that more likely than it is you when you actually uh, remove 2/3 of the stomach from the stomach itself. And if you go back up, I'll show you. They have the three types of the bariatric surgical procedures.
John, can you scroll back up?
Yeah, there it is. And so you got the Roux-en-Y gastric bypass, the sleeve, and you have the gastric band. And it shows which is the best. The Roux-en-Y gastric bypass, which is something that can be reversed, but it's difficult to reverse. The adjustable gastric bypass is not as effective in the long term. And the sleeve gastrectomy, these two are the bottom two are the hardest to reverse. The Roux-en-Y can be reversed more easily than the other two. And as they're saying that the because I think John asked about this last week, what happens when you stop taking the glucagon agonists? And often, if they haven't changed their lifestyle, they go back to the weight they had before. So this is a problem for many Americans. And it's something that trying to find the right procedure for the right person becomes an issue. At one point, people of color were rarely getting these bypasses or bariatric surgical procedures. At this point now, people of all ethnicities up until the point, because of Obamacare and other things, almost everybody was able to get bariatric surgical procedures if they wanted them. Of course, with these changes that coming to pass, it may well be that some of this will change so that people of color will once again not be able to get some of these procedures. Right now, that's not the case. Any other comments about this interesting topic?
Dr. Callender, I somewhere in the article it asked what's the best or what do you prefer to do to take the weight off? And I go back to what we talked about some time ago, and that's eating before 4 o'clock. Stop eating after 4 o'clock. And I mentioned that I did start doing that, and I'm still doing it. And I have lost, I'm kind of at a stalemate right now. As far as losing weight, I haven't lost anything because I keep my weight chart, and I haven't lost any weight maybe in the last month. But I'm still only eating up until 4 o'clock. And I have definitely lost a couple of dress sizes. Maybe, yeah, a couple of dress sizes. So I don't like medicines. I don't like, procedures if I don't have to have them. So and what you mentioned about not eating after 4 o'clock has truly helped me. So anyone who's just trying to, and that way I can eat what I want. So that has really helped me to lose weight more so than anything else I've tried lately.
Well, the simpler the better.
Amen.
And to avoid surgery makes a lot of sense. But what it requires is mental discipline, just as the same thing it requires for those who decide they want to become vegans or vegetarians. It requires mental discipline. But yours is the simple way to do that. Eating, you selected 4, some have used 6, but it works.
Yeah.
That's one way it works.
I was mentioning it to one of my girlfriends, and I had never heard it before the article, and you mentioned it. But when I mentioned it to her, she said, "Oh, yeah, yeah." And definitely, if not 4, definitely by 6 o'clock. She said,
Yeah.
I've been doing that for years, and she was as slim as she could be. So that just reinforced my thought processes.
But it requires a lot of discipline to do that. That's tough. Yeah, but it works. Any other comment, John Buchanan?
Yes. What about those people that I guess you see on some of those programs on TV that weigh 400, 500, 600 pounds?
Yeah, to me, they need surgery. I think for the overweight and the obese people who are under 40 BMIs, there are many options, but to me, for those people who are 400, 600, and 1,000 pounds, they need bariatric surgical procedures in addition to other things. But because just what is interesting is that when you get up to those weights, it's not so much they have such a way of eating that has become their lifestyle that it's so difficult for them to change. And so for many of them, the bariatric surgery is a procedure of choice. But for those under BMIs of 40, I think you can pick or choose. Any other comment about this disease entity that's overtaking the United States, obesity? Then the GLPs, are they getting the right nutrients? This is something we talked about last week as well. But there's more articles that are suggesting that most people, and this has become the rage, is that they have malnutrition because they are eating the right foods after the brain says stop eating, and they stop eating, but then they eat foods that are not nutritious, and so they wind up with malnutrition. And so this article talks about the kind of food preferences that one should have if you are taking the GLPs, because they may want dairy and starchy foods, and that's not going to give them the nutrition that they need. Because one of the things when you get the GLPs is that you lose fat and you also lose muscle. And fat you can afford to lose. The muscle, you need to take intake that allows you to have the restoration of the muscle. And so this then becomes important to emphasize. And so as you go down this article, it points out the foods that they think are recommended to you to be eating so you don't have malnutrition. And it may well be that you get to the point where you don't eat at all, and you that's not healthy either. So there's a intake of fluid and an intake of protein that you need to have in order to overcome the malnutrition that is associated with taking these wonder drugs that have become and this points out the recommended intakes. And there's some degree of carbohydrate, but when you make carbohydrate 90% of what you take and you leave out the proteins, then you have a problem. I think you can go down and it talks more about the recommendations about water and fruits and vegetables. Once again, come thing. Limit sugar sweetened beverages, again, alcohol and caffeine, and of course the fiber is always. And as somebody mentioned, the legumes that. So anyway, this is important to recognize. I don't know if anybody, it's interesting that when you look at most of the people who become octogenarians are heavyweights, and so we don't have a group that probably takes the GLPs yet. But when you take those drugs, it becomes even more important to eat healthy food because you're eating less food. So therefore, the requirement to eating the right foods becomes even greater.
What is sarcopenia, Doc?
Loss of muscle. When you lose fat, you lose muscle also. So you've got to replace the muscle. If you don't replace the muscle, then you have a problem. And it's called sarcopenia, loss of muscle. And then, of course, the fact that the people who are weighing 600 and 800 pounds also have psychological issues that have to be addressed as well. So the malnutrition associated with GLPs is an issue that we have to be concerned about for those who take GLPs.
So, Dr. Callender, are you saying that those people who are candidates for bariatric surgery should also see psychologists
Oh, that's
along?
mandatory. That's mandatory. Before every anybody who's overweight is obese. Part of the uh, preparation is for you to have sociological and psychological evaluation before you take any of the procedures. It is recommended because that's an important part of the disease entity, the psychological uh, aspect of it. Because these people are eating themselves to death. And this is something that reminds me of, I guess it was Lou Sullivan who started putting the nutrition labels on the front of some products. And so the FDA is now proposing that for all of these foods that they have nutrition labels that tell you how much uh, sugar, how much salt, and whether they're low, medium, or high, because the nutrients, fat, sodium, and added sugars are linked to chronic diseases. And that there are countries that already have this, but we don't have it in the United States. And the FDA is proposing that this be done. And this would be another way of addressing the obesity uh, epidemic that we have in the United States. And as you know, the Donald Trump's selection for the Secretary of Health is somebody who has been very critical, and this is one of the areas he could be of great help. Any other comments on the obesity epidemic? What we're trying to do to overcome it? Now, the glucagon drugs, the agonists, have been touted to improve cardiovascular, gastric, hepatic, and renal value. Now these studies are showing, we also know that it's supposed to help mental health as well. Now we're having studies that suggest they have a 40% lower risk of colorectal cancer. And we know it also has lowers the improves diabetes as well. So this is now truly the wonder drug of the 21st century. The problem is that there aren't any long-term studies, and that's what we need to do. And I think that's something that Dr. Perez mentioned the last week, is that this is a cry for HBCUs to be being involved in studies, see what impact this has on the people of color. And the comment about this wonder drug that is impacting just about almost all aspects of our health. For example, there's an article that talks about thyroid cancer, which they demonstrated it does not increase the risk for thyroid cancer. And I think it's going to take time for us to see what happens after the use of these drugs for 5 and 10 years. So to find out what is the real price we pay for these wonder drugs. And this is important that many studies have not found any increased risk of cancer. But the real proof of the pudding will be in what happens after 5 and 10 years of using these medications. Then the fact is that these drugs are temporary drugs. They're using for 1 to 3 years, and then you probably need to stop. But if you don't, what then? So that's why the long-term studies will help us answer some of these questions. And I think the last thing it says is the real critical issue is really making significant lifestyle changes and sticking to them. And that's the thing that I think Darryl has talked about for so long, and the thing that really matters is, and with the thing that Betty is talking about. So doing those things that will endure. Now, this is an article that there was an article we had before that said glucagon prescriptions are meeting the demand and does not fall short. This article takes issue with that. It says that we don't still have enough glucagon products to allow everybody to get them. And the reason is because the demand is ever increasing. And early on, there wasn't that much of a demand for it because it was just used for diabetes. Now that they're using it for so many different things, the demand has increased. And this article suggests that we have not met the need for glucagon products. And time will tell. I know the diabetics had a big problem because they couldn't get the medication for the diabetes because so many people were using it for obesity. It has become less of an issue, but still an issue nonetheless. Next article.
Oh, I got a comment about the GLP-1 drugs. Insurance usually doesn't cover them unless the person has type 2 diabetes. And so if someone just has a weight management problem, it's most likely not to be covered, with the average cost being about $1,000 a month or $12,000 a year. So it's a very expensive drug if you're just using it for weight loss. If you're just using it for weight loss.
Well, and now many people are using it for weight. But one of the interesting aspects, though, is many people who have very obese also have type 2 diabetes. So many of them fit into this category. So they will be covered. And I actually have one of my colleagues actually had type uncontrolled type 2 diabetes, and she got a bypass for diabetes and had controlled the diabetes. She wasn't, she was slightly, I mean, she probably fit into the category of maybe overweight, but she got a bypass for that, for the diabetes. That's what she got it for, and it cured the diabetes. But the Association of being obese and type 2 diabetes is very, very great, so that many of the people who are obese fit into that category of having type 2 diabetes. So they qualify for the drug. But as you pointed out, if you have obesity and not have type 2 diabetes, then getting coverage is more of an issue. This article just shows that there's no increased risk for thyroid cancer. I think that's because the previous article had suggested that thyroid and pancreatic cancer were possibly side effects. As they also said, suicidal ideation was increased, but that also is shown not to be the case when they had large databases. So it does remain to be seen if there are negative aspects of the GLP usage. Okay, let's go to the next slide. Next article, please. This is an article that talks about whether you have obesity because you have high BMI or you have high body fat, or just redefining what type of obesity you have make a difference. And I think that what you call it is not what matters. What really matters is that if you're actually obese, then it's unhealthy, and it's a disease condition which is devastating to your health, and it's often associated with hypertension, diabetes, and other malfunctions. So what you call it is not as important as how you manage it and how you eliminated it, because it is not good for your health. As we had indicated before, certainly the only place that fat is perhaps of merit is in the butt, but anywhere else it's hazardous and associated with risk to your health, and it needs to be overcome. So it's not really an issue of what you call it. It's an issue of if you have obesity, it needs to be treated like any other disease. So we need to lose the weight that is killing us. That's the bottom line. Regardless of what you call it, and of course the stigma that is associated with it has become less, as you can see. Many of the commercials now have people who are overweight in the commercials, kind of pointing out that's okay to be fat, but actually it's not okay to be fat. So I think in many ways that's a mistake to glorify being obese. But that's the way we are today.
You know, Dr. Callender, I've seen those commercials. Those people that you're talking about, to me, they're pleasantly plump. They're not, you know, big and fat.
They're overweight.
They're all overweight, but
no butts. They're overweight.
Yeah, they're overweight.
You can call it pleasantly plump if you want to, but they're overweight, and it's a disease like any other disease. It has ramifications that are killing you. So, and I think it's a mistake to pacify people by calling it pleasantly plump. But in point of fact, it's a disease entity. It's a well-known disease entity. But we like to glorify everything. So we do that again. Any other comments? On my comment too, because you could take issue with that. That's fine.
I think you really have to come to terms with it yourself and make up your mind to change it.
Yeah. Society's not going to do it for you.
Well, fat shaming actually works. They don't have a lot of obesity in China because their culture fat shames.
They culture what?
Their culture will fat shame overweight and obese people.
Oh, really? How do they do that?
So, well, okay. The comments, just the regular comments, like Chinese will say to an overweight person, "Oh, you fat," derogatory. And people are
Fat
more
shaming.
likely to do something about it if
Yeah.
they have derogatory comments about their appearance.
Yeah, and of course we don't like that anymore, so we don't do that anymore. And so, yeah. Okay, that's an interesting comment. Thank you, Darryl.
Maybe Kennedy will bring that back here in the U.S.
Maybe, maybe, yeah. We'll have a lot of protestations.
But his friends are too greedy to allow that market to go away.
This is just a new finding that serum uric acid usually connotes gout, but they are finding that certain serum uric acid levels predict non-alcoholic fatty liver disease, which of course is dangerous because it leads to steatotic liver disease, which requires liver transplantation if it's not treated. And so this is a new finding. It's going to be interesting to see how we move forward now that this has been brought to our attention. Non-alcoholic fatty liver disease is increasingly a reason for liver transplantation since treatment for hepatitis C has been so effective at eliminating hepatitis C as a cause of end-stage liver disease. This is interesting because this was in China. And the question is this true in the United States as well, or is it only true in China? So we have additional studies that need to be done to find out.
Which requires open communication.
Yeah, right. Okay, let's go to the next one. This is something that I thought you'd be interested in. We had many questions about osteoporosis and screening in women over 65. Say older women, they specify women over 65 and postmenopausal women. And it's interesting because what they recommend as a screening is something that we talked about many times is the bone density study. That X-ray, that imaging looks at the bone density and bone mineral density and identifies whether you're at risk for osteoporosis, and if so, puts you on medication. Now, you notice they just say for women. They don't have the data to indicate that it's appropriate for men. They do have the data that indicates that screening is important for women over 65. And that if you find that you have a bone mineral density deficiency, then that there are treatments that can be given to prevent fractures, because that's what That's the enemy of osteoporosis, is a fracture that can occur as a consequence of uh, the weak bone. Any comment or questions about this? We've talked about this on a number of occasions, but now they're coming to the point that they are actually requesting that screening in women over 65 be done, and if you find it, treat it. Any comments about that from you?
Dr. Callender,
Yes.
should that not be a routine? Well, I don't know if routine, but certainly regular uh, bone density test, like your annual or every 2 years or whatever, um, breast mammogram. Shouldn't that be something that's more regular about your physical exam?
Well, that's what they were recommending, but they had not recommended it as a screening process before. So they're
Mm-hmm.
making it, they're doing what you are suggesting and saying that this now should be done in all women over 65.
Mm-hmm.
So they're saying what you have just said, and that it should become a part of your exam if you're over 65. And a woman, it doesn't say that for men because they don't have the data for
Mm-hmm.
men, but it does say that for women. Exactly what you just said.
And I see here lately um, that, well, since COVID, I kind of understood it at first, but I really don't understand it now, that when you go for your physical, your annual physical that Medicare wants you to have, um, I know most people on this call don't know about that, but um, they want you to have a physical once a year. And uh, here lately, for the past couple of so years, my um, primary care physician only does a annual check. In other words, she sits and talks to me. Very little touching, if any. And I, I I've been in the medical profession, as a nurse, and it just seems rude to me that they've stopped doing. I hear other people say the same thing, that the
Yeah,
doctor didn't even touch him, just
I
talk
heard
to him.
that. Yeah, I think Betty told us the same thing. Dr. Price, you have any comment about that? Because I agree with you
Yeah.
that's going backwards.
Mm-hmm.
It is, and many practices, you are not seen by the physician. You're seen by the nurse practitioner, and it's primarily to make sure that you've answered a checklist
Mm-hmm.
of things that are going on. And the loss of continuity in that is horrible. The fact that there's no touching, that's horrible. Um, I, it's 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 horrible. Uh, however, you know, however, we can do something about it.
What can you do about it, especially with this new administration? I
That's
wonder what you can do about it. I doubt that you can the problem is that they're trying to make it as simple as possible. For example, they don't even do urine proteins for people of color
Right.
60,
Right.
which is ludicrous because we need it more than anybody. But nowadays, I agree with your comments. but I don't know what we can do about it. That's the question. What can the NMA do about it? What can AMA do about it? What can anybody do about it? That's it.
We've got to, we've got to fight. We can't
Okay.
allow it,
Well,
to
I haven't
stay.
seen the NMA or the AMA or anybody else doing anything about it.
That's true. That is very, very true. But I guess we have to raise our voices, and we gotta, whatever entity and whatever coming together we need to do it.
Okay,
We
John.
need. Go ahead.
Okay, John Buchanan.
Yes, Dr. Callender, I've had annual physicals for probably 30 years now. And I've had them for over 20 to be a scuba diver. You have to get, cleared. But I've gotten into the habit of arranging for the lab tests myself before the physical. You know, I think the doctor should have that information before the physical. Otherwise, you would have an exam, then the doctor say, okay, go to the lab and get these tests done. I think I think you should be proactive with that. So I think, half of it for me is, looking out for yourself. Um, if,
Well
if,
spoken.
if, if you know the doctor's not hands-on, tell the doctor, you need to look at this. What about this? Ask questions. Bring your medication with you when you come for your physical. Be proactive for yourself.
Thank you for your comments. Betty, you have a comment? It's 10:30, so any comment, Betty?
Yes. I know you all remember when I said last year my physical was a telecall. And so
Yeah.
I have been proactive. I have a meeting with my doctor this year. So
Really?
I had postponed it.
Can't hear you.
You made yourself mute.
We can't hear you.
You
Sorry,
muted yourself, Betty.
I'm sorry.
Sorry.
I said my husband is a diabetic, so he goes every 3 months. We have the same doctor. So when he at the beginning of at the end of last year, when he was scheduling his appointments for this year, he said, for his first appointment, he said, and also schedule my wife. So she scheduled us for January, but of course the snow came, so we canceled. So we have an appointment now in February. So I'm going to see what she does when I get there and she sees me face to face. And
Yeah.
I'm going to see what kind of exam I'm going to have. That was my proactiveness. I went from tele to at least a face to face.